That's why she's chief. A few questions came up. One of the questions. So one of the I'm already forgetting what some of the questions were. So one of the questions had to do with the refocusing pulse and exactly how the refocusing pulse flipped. Seemed to flip some protons rather than others. And the answer to that is I'm going to have to give it some more thought. So I apologize for that if I confuse people on that, because I guess as I think about it, I'm probably a little bit confused myself. That's question number one. Rachel, what was your question again? Ooh.
This is embarrassing, but
no, it's not embarrassing.
So no, I was just trying to understand the mechanism of when you explained it well to me, so let me try and reiterate my own question, working backwards. Basically, it's the second gradient that we put on. That is the one that allows us to know the signal from what has diffused. So the free water that has diffused, because we give that second gradient, that is enabling us then to lose that signal and then to enhance or to see just the signal, what is hindered or restricted.
Yeah, excellent. So just to clarify, we apply one gradient which causes dephasing. If protons don't move at all, in other words, if they're completely restricted, then the next gradient refocuses them perfectly and we have high signal. So perfectly, completely 100% restricted protons get dephased, they get perfectly rephased, and the rephasing brings the signal back, so high signal. If the protons are moving a little bit, they're still restricted, but they're not purely restricted, they're not 100% restricted, they're moving a little bit, then they get dephased, they get like 80% rephased, but not 100% rephased, so they still give off quite a bit of signal, but not quite as much. Now let's say the protons are actually not restricted at all, but they're hindered, so they're moving a modest amount. They will be refocused, but less, so they'll have even less signal. What about free water? Free water is moving around quite a bit, so that gets refocused even less, lower signal. What about perfusing water? Now that's moving around the most, so that doesn't get refocused at all, that loses all signal, okay? Now, another question that was sort of related was, well, what's the difference between different tissues and why they look different? And so you kind of have to sort of make a mental picture of this. So let's look at a cancer. Let's look at a classic cancer. So a classic cancer is going to have lots and lots of little tiny cells and no extracellular water because the cells are too tightly packed together. So what will that cancer look like? Well, does it have any hindered component? Remember, the hindered component is the extracellular water. So if there's no extracellular water, there's no hindered component. So the only component is restricted. How restricted is it? Very restricted. Lots of little tiny malignant cells, right? So a classic cancer, a cancer that read the textbook, will be very, very restricted. It says no hindered component, all the signals coming from the intracellular compartment, which is very restricted. Very high signal in DWI. What about an HCC? Because it hasn't quite read the textbook. So now the cells aren't quite so tightly packed, and because they're not quite so tightly, and they're not so small. So now the component that's intracellular, the restricted component, is not that restricted because the cells are bigger. And there's an extracellular component because the cells aren't that tightly packed together. That's the hindered component. And so you might imagine that with some hindered water and some modestly restricted water, HCC won't look as bright as a classic cancer that read the textbook. What about a normal tissue? Well, a normal tissue, like normal liver, will now have cells that are fairly big, and these cells aren't that tightly packed. So the restricted component within the cells isn't that restricted. The hindered, and there's a lot of hindered water because there's a lot of space in between the cells. So now that tissue won't be that bright. What about pure water? Well, pure water has no physical barrier, so there's no restricted component whatsoever. It's just pure water. What about a cyst? Well, a cyst, or what about an abscess? Abscess is a good example. What about an abscess? An abscess has no cells. It's just pus, purulent material. A lot of proteinaceous debris. So there's no restricted component, but there's lots of hindered water. It's all hindered water, and it's very hindered because of all the fibrinous debris. So an abscess will look darker than a metastasis or than a cancer because it's not restricted, but it will look brighter than pure water because of all that fibrinous debris. So it's hindered water, but it's very hindered, as opposed to, say, maybe a minimally complex cyst, which is hindered, but only mildly hindered. So I'm not going to go through every possible permutation for the next hour, but you can start doing sort of mental exercises. If I had a tissue that was very restricted and had no hindered, what would it look like? If I had a tissue that was very hindered and had no restriction, what would it look like? You can start sort of imagining for yourself what these things might look like. The key is that in the year 2017, we don't have a way of teasing this stuff apart, but Anders and Nate are working on ways to start teasing this stuff apart. Which then brings up a very interesting question that was raised by, I don't know his name. Over there, sorry. What's your name? Paul. So he has a very interesting question. Can RSI someday tell the difference between a malignant node and a benign node? Because if it can tell the difference between restriction and hindrance, wouldn't it be able to tell the difference between a benign node and a malignant node? The problem is that lymph nodes, normal lymph nodes, are what? Lots of tiny little packed cells. So normal lymph nodes have very, very restricted diffusion. In fact, nodes that contain metastases under the microscope, now no one's ever done this, but under the microscope, if you look at metastases to a lymph node under the microscope, the metastatic component has bigger cells and less tightly packed cells than the normal node. So I don't think it's ever going to be possible to detect malignant nodes, to differentiate malignant nodes from benign nodes using RSI, because the malignant component may be less restricted than the benign component. And to find, due to volume averaging effects, to find within a node an area that's less restricted, I think will not be possible. Or even if it is possible, I don't think it's going to be the way to go. I think we're going to have to look at more effective mechanisms. So RSI is very powerful for detecting nodes, extremely powerful. I don't think it's going to be able to differentiate benign from malignant. Okay, but I don't know that. That's my speculation. I think okay. So MR contrast agents. We've already touched upon this a little bit. This should have been my first disclosure slide. There's lots of physics, and I am not a physicist, so I am struggling through this stuff at least as much as you are. Please do not fall asleep. Anyone recognize this movie? Okay, 2 people recognize this movie. For those of you who don't recognize, 3 people recognize this movie. This is Clockwork Orange, and basically, this was a very bad guy, and the way they told him, they convinced him not to be so bad is they made him watch violence, and they kept his eyes propped open so he couldn't stop watching it. So if you fall asleep, this might be what I do to you, okay? All right, so this lecture will have 5 vignettes, and we're probably not going to get through all of them because the pizza will be arriving soon. But we're going to talk a little bit about the chemistry and physics of gadolinium-based contrast agents, the landscape of gadolinium-based contrast agents, extracellular agents, gadoxetate, also known as Eovist, and then finally, what contrast agent to use. Okay, chemistry and physics. So, teaching point number 1, gadolinium is invisible on clinical MRI scanners. So I asked my MR technologist to scan a vial of gadolinium, and here's the vial. Can anyone see the gadolinium? This is pure gadolinium. So gadolinium is not visible. We do not image pure gadolinium. What we image is the effect of gadolinium on water. So gadolinium shortens T1 and T2. So I think I'm going to show the same thing that was confusing before. So let me see if I can clarify this. So I'm going to show time on the x-axis and signal on the y-axis, but I'm going to show 2 different kinds of time. So the first time I'm going to show is T1 relaxation time. So as a function of T1 relaxation time, a tissue without GAD will recover. And if I wait an infinite amount of time, this tissue will eventually get to where? it'll eventually get to m naught. But I don't wait an infinite amount of time. I only wait a certain amount of time called my repetition time. So after I wait a repetition time, this is how much longitudinal relaxation this tissue has relaxed to, recovered to. Now I'm going to switch gears and show a different kind of time on the x-axis. Instead of recovery time or repetition time, I'm now going to show echo time. So after I reach here, I give my refocusing pulse, and after I give my refocusing pulse, this gets shifted into the transverse plane, and then it starts to dephase. And as it's dephasing, it's going to lose signal. And this is now echo time. So this was TR time, this is now echo time, and if I waited an infinite amount of time, this signal would decay down to 0, but I'm not going to wait an infinite amount of time, I'm going to wait a certain echo time TE. So this is recovery time in the z-axis, and this is now TE time in the XY plane. So I know this is confusing, but I hope now with that explanation this sort of makes sense. So with no gadolinium, with this TR and this TE, this is how much signal I have. If I give some gadolinium, I recover more during TR time. During TE time, I dephase more, I lose signal, but the net effect is that I have more signal if I give a bit of gadolinium than no gadolinium. If I give more gadolinium, then I have more signal. If I give even more gadolinium, though, at some point, the signal loss causes me to lose signal, and if I give too much gadolinium, a gallon of gadolinium, I have no signal whatsoever. So the point of this is that there is a magical amount of gadolinium that you can give, given your TR and TE, that will maximize the signal. But this is definitely a case where more is not necessarily better. After a certain point, giving more gadolinium, you actually start losing signal because the gadolinium causes so much dephasing during this TE time. And use the shortest TE possible. I already showed this. Oh, sorry, I need to hover my mouse over here to prevent the lag, sorry. Now, with standard sequences and gadolinium concentrations, the T1 effect is much more important than the T2 effect. I already showed this image before. Gadolinium increases the signal to noise on T1 weighted images. The gadolinium has no effect on T2 weighted images with the exception of one structure. So which one is pre-gadolinium? Which one is post-gadolinium? And the rhetorical question answer is you got to look for the bile duct. This was done with Eovist. Bile duct is bright here, pre-Eovist. Post-Eovist, the bile duct goes dark. I already mentioned before, does gadolinium have any effect on DWI, clinical DWI? The answer is no. Which one is pre? Which one is post? 4 different B values. And the answer is this is pre, this is post. Okay, so now let's talk some chemistry. Here's the periodic table. Does anyone see gadolinium? So gadolinium is down over here, gadolinium. It is atomic number 64, and it has, looks like an atomic weight of 157.25. So please, very important, you cannot be a practicing radiologist without having committed this to memory. So why are we picking gadolinium? Well, the reason we pick gadolinium is that it has 7 unpaired electrons in its inner shell. What does that mean? Well, these are electrons that are not involved in chemical reactions, so they're always unpaired. It doesn't matter whether you put gadolinium on DTPA or DOTA or BOPTA or whatever, you always have these 7 unpaired electrons. Okay, that's sort of helpful, but I still don't understand. What does an unpaired electron do? How does that help me? Well, remember that protons are magnetic dipoles. Turns out that each unpaired electron is also has a magnetic dipole moment. So just like a proton has a magnetic dipole moment, an electron has a magnetic dipole moment because protons have spin and electrons have spin. And their spins are the same. But protons are much, much bigger than electrons. So an electron has a lot more wallop for its size than a proton. How much more wallop? 657 times more wallop. So you'd much rather get punched in the face by a proton than by an electron. These electrons are very powerful. 657 times more powerful than a hydrogen. And there's 7 of them, right? There's 7 unpaired electrons. So gadolinium, I'm not smart enough to figure this out, but 7 times 657, that's how much more powerful gadolinium is than proton at disturbing the magnetic field. So electrons cause magnetic field fluctuations, and the more unpaired electrons you have, the more magnetic field fluctuation you create. So this one little electron times 7 in a gadolinium atom causes quite a bit of fluctuation of the magnetic field, and it's that fluctuation that causes T1 and T2 relaxation. So here's this gadolinium. I lost my mouse. Here's the gadolinium, and here are its 7 unpaired electrons, and here's a bunch of water molecules, oxygen and 2 hydrogens. All these little Mickey Mouses are water molecules. And let's now have this gadolinium go through here, disturbing the magnetic field, and as it's disturbing the magnetic field, it's causing the hydrogens in these water molecules to relax because of the relaxation, the magnetic field perturbations. Now also notice that this gadolinium with its 7 unpaired electrons doesn't just relax one water molecule, it causes 1 million protons per second to relax. So gadolinium is very powerful because of this amplification effect. We're not imaging gadolinium, we're imaging the effect of each gadolinium atom on 1 million water protons per second. Huge amplification. This is fundamentally different than CT, where one iodine molecule or atom blocks 1 photon. And just to show you the difference, here's a CT, and we see a lesion in the liver, and you wonder what that lesion is. You sort of hallucinate. There might be a little puddle of contrast here, a little puddle here. By the way, this is pre-arterial portal venous. But this person has metastatic disease. This person has breast cancer, and maybe you don't feel comfortable calling this a hemangioma, so you do an MRI. And this is what it looks like on MRI, and now it's obvious that this is a hemangioma. So why is the gadolinium in this hemangioma on MRI so much more obvious than the iodine in this hemangioma on CT? It's because of this amplification effect. MRI is about 1,000 to 10,000 times more sensitive to gadolinium than CT is to iodine. So I'm not saying that makes MRI better than CT, I'm just saying that sometimes you cannot see the enhancement on CT, and you can see the enhancement vividly on MRI because of this amplification effect. Now, this amplification effect can get measured as something known as the relaxivity. So the relaxivity, which is little r, is the change in R1. Sorry, I didn't make something clear before. Before I was showing T1 relaxation curve. So T1 is the time constant. R is the rate constant. So what this is basically saying is that the relaxivity of a gadolinium-based contrast agent is measured as the change in the relaxation rate divided by the gadolinium concentration. So the change in the relaxation rate is the bang, the gadolinium concentration is the buck. So if you can change the relaxation rate by a lot with very few gadolinium atoms, you have high numerator, high bang, low denominator, low buck, high bang to the buck. So gadolinium-based contrast agents that have high relaxivity cause more brightening than gadolinium-based contrast agents with low relaxivity. And let's just skip this in the interest of time. So this is a tissue before giving gadolinium at a TR of 5 milliseconds. This is how much signal we have. If we give a regular gadolinium-based contrast agent, this is how much signal we have. If we give a gadolinium-based contrast agent with higher relaxivity, notice that we have higher signal. So all else being equal, choose the contrast agent with higher relaxivity. So this is an agent with high relaxivity, this is an agent with intermediate relaxivity, and this is an agent with no relaxivity. We'll come back to this later. Gadolinium is very toxic. If you gave pure gadolinium to your patient, you will kill your patient. Gadolinium is a competitive inhibitor for calcium. It's a great way of killing people. There's one person, no, I won't go there. Okay, never mind. Won't go there. Gadolinium is very toxic, so we never, ever, ever give pure gadolinium. We must chelate it. So we take this gadolinium and we attach it. So there's usually 7, I think it's coordination sites, and we attach it to this molecule. And this molecule could be DTPA, it could be BMA, BMEA, etc. There's all these different chelators that we can attach this gadolinium to. This one, this molecule, anyone recognize this one? This one is DTPA. So for most of these things, there's 9 coordination sites, and 8 of the 9 coordination sites are occupied. So let's see how smart you are. If 8 of the 9 coordination sites are occupied, how many of the sites are unoccupied? 1. 1 is unoccupied, right here. So there's 1 unoccupied site. 1 is free. What do we do with that unoccupied site? Well, water will get into that unoccupied site and bounce out and become relaxed. And here we have our gadolinium. Here it is in its molecule. Here's the molecule shaking around now, and it's and the shaking is to show that it's causing magnetic field fluctuations. And water molecules will come into that unoccupied site, get relaxed, and move away, and another water molecule will come in and get relaxed and come out, and another water. So we're going to do this 1,000 times now. And you can see that over the course of 1 second, 1 million water molecules will get into that coordination site. Now, sometimes too fast is not good. So here is this proton precessing at its rate, and here is these electrons causing magnetic field fluctuations. And so you can see that if these are fluctuating too fast, it isn't able to interact ideally with the water molecule. But if you take this gadolinium contrast agent and attach it to a larger molecule, like a protein in the blood, then this gadolinium-based contrast agent will vibrate more slowly. And if it vibrates more slowly, it interacts more effectively with the water molecules. So what I'm trying to say is that gadolinium is pretty good at relaxing water, but it tends to vibrate too fast. So to make gadolinium really, really, really good at relaxing water, to give it a lot of bang for the buck, you want this gadolinium, or strictly speaking, you want this chelator to bind to a macromolecule like a protein. So any gadolinium-based contrast agent that binds to proteins, so if you ever read that this is contrast agent binds to proteins, what it's telling you is it's vibrating more slowly, it's more effective at relaxing water, more bang for the buck. If you have an agent that doesn't bind to proteins, that means that it's not as effective at causing relaxation. So this chelator is what allows us to give gadolinium without killing people. This chelator determines how much of the contrast agent gets excreted from the kidneys. It determines how much of this contrast agent gets taken up by liver cells and excreted into the most important, third most important organ in the human body, which is the biliary system. This chelator is what determines whether it binds to proteins, and we now know that if it binds to proteins, it has more bang for the buck. And finally, this chelator determines just how stable the gadolinium is. So some chelators hold on to gadolinium tightly, and some not so much. And why does that matter? Well, we just said that gadolinium is toxic. So if we have a chelator that binds to gadolinium loosely, then when we give the patient gadolinium in the form of a chelator, some of it will get out, and some of that free gadolinium might deposit in the brain or in the soft tissues. And we know that that can cause nephrogenic systemic fibrosis We're not yet sure what other side effects that might have, but it can't be good to have gadolinium depositing in your tissues. So in general, all other things being equal, you want a chelator that holds onto gadolinium tightly. You want a chelator that binds to proteins. You may or may not want a chelator that gets into the liver. You may or may not, depending on what you're trying to image. But the chelator determines the chemistry and the dynamics of the agent. Okay, so that was the end of vignette 1. And the pizza is coming here, or do we stop now? Okay, so let's briefly talk about the landscape of gadolinium-based contrast agents. So contrast agents in the United States, here's the landscape. The very first one that was ever approved, 1988, gadopentanate, GD-DTPA, known as Magravus, 1988. First contrast agent approved in human beings in the United States. You can see that subsequently there were other agents, 92, 93, 99, 2004, 2008, 2010, 2011, 2013. And then there were some agents that were not based on gadolinium. Iron particles were released or approved in 1996. Manganese agent was approved in 1997, but right away you can see that most of the approved agents were released with gadolinium and only a few with other agents. Now, this agent here, Ablavar, is a blood pool agent. So this binds to proteins so strongly that it doesn't get out of the blood space. It stays inside the blood. This one binds weakly to proteins. This one also binds weakly to proteins. So these two bind weakly to proteins enough to give them more bang for the buck, but not enough that they just stay in the blood. This one binds to proteins so strongly that it gives you a huge amount of bang for the buck, and it doesn't get out of the blood. It's a blood pool agent. All the others are extracellular agents, and then these have funny properties, which we're not going to talk about further today because 3 of these agents have been discontinued. So notice that in the United States right now, we don't have any iron particles. We don't have manganese particles. We just have gadolinium-based agents. And of the gadolinium-based agents we have, oops, this is in the wrong place. This should be here. Sorry about that. It's Ablavar that's, I think it's actually already discontinued. So we only have these other agents. I need to fix this slide. I apologize. Something else to keep in mind. It takes about 15 years and $200 million to bring a contrast agent from discovery to the market. Pretty expensive. And here's something else to think about. If you look at worldwide sales of drugs, contrast agents 1%, therapeutic drugs 99%. So if you wonder why there have only been about 10 contrast agents approved in the United States since 1988, it's because it takes 15 years, $200 million, and at the end of all that, you're not going to make a lot of money. Not only will you not make a lot of money, if you happen to be the manufacturer of Faradex, you're making no money. If you're the manufacturer of Tesla-Scan, no money. Ablavar, no money, even after approval. So that's one of the reasons why I think that molecular imaging is going to have a very difficult time becoming a clinical tool. And I think molecular imaging is going to be predominantly a research tool because it's just hard to imagine taking molecular agents through that $200 million validation process in order to have such a small percent of the market. And I could be wrong, but I just think that molecular imaging is going to be a research tool more than a clinical tool, at least in general. Now, what are these 10 different contrast agents? What's the difference? They're all gadolinium, right? Gadolinium, gadolinium, gadolinium. It's the chelators. So these are the chelators, and again, You cannot be a practicing radiologist without memorizing the chemical structure. So I think about this all the time. Every time I look at a liver, I ask myself, what's the chemical structure of the chelator? And that chelator determines whether it's, here are the names of the chelators, and that chelator determines the name of the drug. So gadopentotator magnivis is DTPA, Omniscan gadodiamide is gadolinium DTPA, BMA, etc. So we're not going to go through this whole thing, but just be aware that it's these chelators that allow companies to market their own particular version of a gadolinium-based agent. Now this is a long list, and so rather than, it's not that many compared to some drugs, but it's a fairly long list, and it's hard to memorize all this. So let's put these into classes. So here we have extracellular agents, and we have, and these distribute in the extracellular space excreted by the kidneys. No protein binding for these, and most have low relaxivity because no protein binding. Most have low relaxivity. Then we have an agent that gets taken up by hepatocytes to a relatively low amount, and that's gadolinium-Based, gadobenate. So this is excreted mainly by the kidney, a little bit by the liver, because it gets taken up a little bit by the liver, but not much. Mild protein binding, intermediate relaxivity. Then we have this agent, gadozetate or Eovis, high hepatobiliary phase uptake. Because it has high hepatobiliary phase uptake, it gets excreted by the kidneys and the liver equally. Moderate protein binding, high relaxivity. And finally, we have this blood pool agent, very high protein binding, very high relaxivity, very prolonged blood pool dwell time. This is no longer available in the United States, so let's say goodbye to that. And then from a practical consideration, this gadobenate behaves a lot like an extracellular agent clinically. So I like to think of it as there are extracellular agents, and then there's hepatobiliary phase agents. So you either have gadozetate or you have an extracellular agent. And of these extracellular agents, this one has the highest relaxivity because of its protein binding. This one is probably the safest because it has the highest the strongest chelation of the gadolinium. Okay, so let's keep moving and now talk about extracellular agents. So let's focus on the liver. The liver has a dual blood supply, so here's the heart, and the liver gets fed by hepatic artery. The liver also gets fed by portal vein. Notice that the portal vein in blue gets its supply from the spleen. The portal vein also gets its supply from the mesenteric veins from the gut. So about 25% of the flow gets in through the hepatic artery. About 75% gets in through the portal vein. The blood mixes then in the sinusoids, collects into the hepatic veins, into the IVC, and back to the heart. And this is the blood supply to the liver. So now let's give a contrast agent, and the contrast agent is going to go down the aorta and into the liver via the hepatic artery. And then about 15 seconds later, contrast is going to drain from the spleen and from the gut into the liver and get into the portal vein. So, because it takes 10 to 15 seconds for contrast to go from aorta to spleen to portal vein, 10 to 15 seconds for contrast to go from aorta to gut to mesenteric vein, the contrast in the portal vein arrives to the liver about 10 to 15 seconds after the contrast arrives via the hepatic artery. Memorize this number. This number is actually important, 10 to 15 seconds. We'll explain why that's important in a bit. The liver enhances mainly from the portal venous delivery because that's 75%, but tumors will enhance mainly from the arterial delivery because tumors get fed by the hepatic artery. Notice that the hepatic veins don't enhance until after the gadolinium has made its way through the sinusoid. So that's important. Hepatic veins enhance only after gadolinium has made its way through the sinusoids. And we'll explain why that's important. In fact, we'll explain why it's important now. So we're going to give gadolinium, and we're going to look at enhancement on the y-axis and time on the x-axis. So this is time after injection, and here's where contrast gets into the hepatic artery in red. The artery enhances and then gradually de-enhances. Now this is the tumor. The tumor enhances and then de-enhances. And notice that the tumor enhances 10 to 15 seconds after the artery. Now, isn't that a great coincidence? Because I mentioned on the previous slide that the portal vein enhances 10 or 15 seconds after the aorta. So it turns out that here is the portal vein in blue. So the portal vein enhances 10 to 15 seconds after the aorta, and the tumor enhances 10 or 15 seconds after the aorta. What a great coincidence, because what that tells us is that if we're trying to see enhancement of a tumor, the tumor's in green, we want to see some enhancement of the portal vein. If we don't see any enhancement of the portal vein, we're here somewhere, and notice that we would not expect the tumor to be enhancing. So isn't that a nice coincidence? Now the liver is fed mainly by the portal vein in blue, so the liver really starts enhancing after the portal vein. And the hepatic veins start enhancing after the contrast has made its way through the sinusoid. So after the liver enhancement is when the hepatic veins start enhancing. So this is, notice this is a continuous series. Artery, tumor, portal vein, liver, hepatic veins. It's all occurring continuously, but that's too complicated for us. So we divide it into phases for convenience. The first phase is pretty straightforward, pre. Then comes the early arterial phase. The early arterial phase is when the hepatic artery is maximally enhanced. Then we have the late hepatic arterial phase, which is when the tumor is maximally enhanced. So if you want to image tumors, do you want to do early arterial phase imaging or late arterial phase imaging? I think you want to do late arterial phase imaging. The portal venous phase is the phase in which the liver is maximally enhanced in orange. So it's the peak of the liver enhancement. So that's at 60 to 80 seconds. And then we have the delayed phase at 3 to 5 minutes in which everything is sort of de-enhancing sort of in parallel. Some people call this the equilibrium phase, but LIRADS calls it the delayed phase, and we can talk later why that is. Now, I mentioned earlier that we want to image tumors. And if we want to image tumors, we probably want to do the late arterial phase. And in order to do the late arterial phase, we want to image about 10 to 15 seconds after contrast gets into the aorta. So, do we want early or late arterial phase? I've sort of already answered this question, but just to prove it to you guys, here is a pre-contrast image. And here is an early arterial phase image. Does anyone see the cancer? Patient has 2 cancers. Okay, so someone said there's a cancer in segment 6, and that's correct. Anyone see the other cancer? Segment 8, I think I heard, so either they're seeing the wrong thing or they have their segmental anatomy incorrect. Segment 7, I heard. Okay, but hard, right? 10 seconds later, not so hard. So you want to do late arterial phase imaging. Notice that on the late arterial phase, we have contrast in the portal vein. In the early arterial phase, we don't. So the key to seeing good arterial phase imaging is you got to see contrast in the portal vein. If you don't see contrast in the portal vein, you're too early. But you don't want to see contrast in the hepatic vein. So here's the hepatic vein. If you see contrast in the hepatic vein, you're too late. Okay? Let's do this again. Early arterial phase. Anyone see the tumor? By the way, notice what a beautiful angiogram this is, right? So we see beautiful arteries, right? So if you're interested in seeing hepatic arteries, then you do want to do an early arterial phase, but you probably want to see tumors. Anyone see the tumor? Well, I don't actually see it myself, but now I do. And notice that now we see the portal vein. So if you don't see the portal vein, you're too early. If you see the portal vein, you're probably okay, but you want to make sure that you don't see the hepatic veins. If you see the hepatic veins, you're too late. Okay, so we want to do late arterial phase imaging, and the clue to late arterial phase imaging is that you should see the portal vein. If you don't see portal vein, you're too early, but you also don't want to see hepatic veins. If you see hepatic veins, then you're too late. So if you see hepatic veins, you're out here somewhere. If you don't see portal vein, you're out here somewhere. Okay, so just to now illustrate this, so this is a pretty good arterial phase, not perfect, but it's pretty good. We see aorta, we see hepatic artery, we see portal vein, there's some enhancement in there. We do not see enhancement of the hepatic veins. We do not see enhancement of the hepatic veins. Now some of you might be saying, well, now I'm confused. I don't see enhancement of the hepatic veins, but I do see enhancement of the IVC. Why would I see enhancement of the inferior vena cava if there's no enhancement of the hepatic veins? And the clue is in this coronal image. So why do we see enhancement of the IVC, but not of the hepatic veins? Because of drainage from what? From the kidney. Now, the reason I'm mentioning this to you is don't get fooled if you see enhancement of the IVC on a perfect arterial phase image. A perfect arterial phase image of the liver, you may see enhancement of the IVC. You just don't want to see enhancement of the hepatic veins. And why is this helpful? So we talked about the arterial phase. Why do we get other phases? Why don't we just stop with the arterial phase? I mean, I see a lesion here. I see a lesion here. Why would I need anything other than the arterial phase? Because the later phases also give us information. So notice that this lesion goes from bright to dark. It washes out relative to liver, whereas this lesion holds on to contrast. And that difference is important. So the lesion that holds on to contrast is likely to be what? Benign. And now let's see how smart you are. The lesion that washes out is, notice it's not color-coded green for benign, so what is this? Likely to be malignant. By the way, at UCSD, I don't know about at Navy, but at UCSD, every images come out with these arrows color-coded, so I don't know what I would do if they weren't color-coded. Now, we don't just want to look at the presence of enhancement, we want to look at the morphology of the enhancement. So notice here that we have arterial phase, and here we have diffuse enhancement, and here we have rim enhancement. Is there a distinction? Both patients have cirrhosis, and remember at the beginning, let's see who remembers. Patients with cirrhosis are at risk for what two cancers? They're at risk for HCC, they're at risk for cholangiocarcinoma. So which one's the HCC, and which one is the cholangiocarcinoma? Well, some of you may remember that the cholangiocarcinomas are the ones that tend to be cellular on their periphery and stromal on their center, which is why they have restricted diffusion on the outside and not so restricted on the center. It turns out that they're also quite vascular in their periphery and very hypovascular in their center. So arterial phase rim enhancement in the setting of cirrhosis very strongly suggests cholangiocarcinoma, and diffuse enhancement, on the other hand, suggests hepatocellular. So when I see diffuse enhancement, I think LR3, LR4, or LR5. If it washes out, I'll think LR5. But with rim enhancement, no matter what it does, I'm going to think LRM. Now this ended up being biopsied, and this was I think this ended up being a sarcomatoid cancer, not a cholangio. Now, does rim enhancement exclude HCC? The answer is no. HCCs are so common in the cirrhotic liver that something that doesn't look like an HCC very well still may be an HCC. It's just that you can't call this an HCC based on imaging alone. So when I see rim enhancement, LIRADS-M, biopsy, possibly an HCC, possibly a cholangio. This, no way this is a cholangio. That's the difference. Okay, let's move on to